Here today, and my task is to give an introduction to common learning disabilities and cognitive impairments or challenges that individuals with TS might face. My name is Knickmeyer. I'm an experimental psychologist by training. That means I use scientific tools to understand how people think and behave. And I work at Michigan State University. Most of my research is focused on understanding how a genetic variation like that in Turner syndrome, as well as environmental factors shape brain development in infancy and early childhood. So the outline for today's talk, I'm going to start with my 5 key takeaways. So if you need to be somewhere else, you can just listen to those slides and run. So these are kind of the big ideas I'd like everyone to take home with them. But then I'll expand upon each of them in more detail. So we'll talk about specific cognitive challenges as well as cognitive strengths that individuals with TS might experience. We'll talk about academic performance and psychosocial function, educational success and employment, the impact of hormone therapies, as well as general recommendations from the 2016 clinical care guidelines. And we'll talk a little bit about what we don't know and hope to learn in the future. So takeaway number 1. So Turner syndrome is associated with both cognitive strengths and cognitive challenges, and those can influence educational attainment and quality of life. Takeaway number 2, cognitive and psychosocial challenges associated with TS overlap with other diagnoses, including attention deficit hyperactivity disorder, specific learning disorders. I'll go into more detail on those later. Social communication disorder, which is a condition that is sort of specifically focused on difficulties using language in a social context. Autism spectrum disorders and developmental coordination disorder, which is related to motor skills. And that means that interventions developed for those other conditions, even though they're not exactly equivalent to Turner syndrome, may have similar positive effects when applied in people with TS. Takeaway number 3, people with TS are highly individual. So not everyone with TS is going to experience the challenges I'm discussing in today's talk. And some are going to experience disabilities and impairments that are uncommon in TS, but still need to be addressed. Takeaway number 4, cognitive and psychosocial challenges change over the lifespan and may improve significantly with appropriate intervention. So these things aren't static features. And takeaway number 5, people with TS are highly resilient. They succeed both academically and personally, despite the challenges that I will discuss. All right, so moving on to the second part of the outline, I'm going to go through some of the cognitive strengths and challenges. And I think the first thing to know is that the majority of people with TS have average or above average IQs. However, about 10% would qualify for an intellectual disability. So this is an IQ less than 75. This is particularly common in certain karyotypes. For example, individuals carrying a ring X chromosome may be more likely to develop these. And there's a general pattern where the full scale IQ and the verbal IQ tend to be higher than what we call performance IQ. It's not a great name, but what it really means is kind of visual spatial skills. So you can see that down here in this particular figure, where you really see individuals with TS, whether it's 45X or other karyotypes, performing very well in terms of the verbal IQ, but then performing lower on perceptual reasoning, working memory, and as well as processing speed. If you've ever had an IQ test, as an older individual, it might have looked a little like this in childhood. So there are verbal questions, there are visual spatial puzzles to carry out. Early on in life, there's things you might think of as kind of baby IQ. So the Mullen is one of those, really looking at how children are moving through the normal developmental trajectory for language and visual perception and motor skills. Let's see. Oh, sorry, I've got to turn that off. There we go. So each of these, I'm going to tell you a little bit about how what we find in the lab might manifest in real life, as well as diagnoses associated with it and what kind of interventions could be done. Let's see if I can move this just then. So in terms of IQ, If intellectual disability is present, that might manifest in poor adaptive skills and the need for additional support and accommodations to optimize the adaptive function and to improve educational and vocational attainment. And as I said, intellectual disability is kind of the official diagnosis that might be applicable here, and again, about 10% of individuals. All right, so the next domain I'm going to talk about, I'm going to start talking about specific domains, is something we call the domain of attention, working memory, executive function, and cognitive control. So most of us probably know what attention is, right? Our ability to direct our focus to different areas, the ability to ignore outside stimuli that might be interfering with a task or a goal that we want to achieve. Working memory is the kind of memory that you hold for a short period of time to help you get a task done. So that's in contrast to something like episodic memory, which is about memory, for example, for specific events that happen to you, or something like semantic memory, which is memorizing, what words mean. And then executive function describes a whole suite of skills that help us to carry goal-oriented behavior. So in TS, we often see deficits in attentional control, but there's preserved orienting attention, so the ability to direct your attention where you want it to go. And then there are inconsistent results for what we call sustained attention, which is being able to maintain your vigilance, your attention for a long period of time. In the lab, for example, this might involve staring at a screen for 20, 30 minutes and only hitting a button when you see an X. In real life, this might mean paying attention during a meeting at work. We often see deficits in verbal and visual spatial working memory, running about 1 to 2 standard deviations below the mean. And an executive function, the domains that are most effective tend to be planning, response inhibition. That means preventing yourself from doing something you want to do, but might not have good consequences, right? You don't want to haul off and punch the person who, just made a negative comment about you. Mental flexibility, which is being able to think about problems in new and different ways. There is some evidence that these problems may be limited to or strongest in those with ADHD symptoms. I'll show you more about that in a minute. What does this look like in real life? So attention problems can manifest as distractibility, having a hard time staying on task. They manifest as poor organization. So in a child, perhaps difficulty remembering to bring their homework home from school. My own 2 children have ADHD, and they lost their book bags on the first day of school. It's very impressive. And an inability to stay still or be up and moving. Potentially difficulty with multitasking, not easy for anyone, but certainly more difficult. Performing mental calculations, right? Because when you're having to think through, say, a math problem in your head, you have to remember each component without having it down on paper. So really talking about how you hold information in the mind's eye. For example, if you're running to the grocery store and you're trying to remember your list versus having it written down. In terms of executive function, this could be difficulty with planning out something complex that you want to do, thinking flexibly when the plan you had goes out the window and you have to think of a new way to approach a problem. And as I said, inhibiting thoughts and behaviors. So some girls with TS will qualify for a diagnosis of ADHD. We think it's probably about 25%. If there is suspicion that this happens, you want to get neuropsychological testing to confirm the diagnosis. ADHD can be addressed with behavioral therapy, particularly teaching parents ways to manage and train their children. Children with ADHD will often get classroom modifications to help enhance their in-class behavior. And in some cases, medications for ADHD would be indicated. So I wanted to show you a little more about ADHD and executive function. This is data from Alan Reese's group and Tamar Green. So what you see over here is scores on a particular attention and executive function measure. It's the NEPSI-2, which is something you might find you or your child taking in a clinic. So you can see that neurotypical people score about here. That's the mean. And you see that those with Turner syndrome as a group score lower, and actually quite comparably to kids who don't have ADHD, don't have Turner syndrome, but do have ADHD. If we break that up and we look specifically at people with TS who do and do not qualify for the diagnosis of ADHD, you can see that there still is some executive functioning challenges for some people, even without an ADHD diagnosis. So I think that's important to remember. Even if someone doesn't have ADHD per se, they may still need support in these domains. But those skills appear to be lower when you've actually received the ADHD diagnosis. All right, the next domain I'm going to talk about is visual spatial, and I'm going to just talk about visual spatial, talk about perceptual motor later. But typically, some individuals with TS will show poorer performance on visual spatial as well as perceptual motor tests. And in real life, this might manifest as difficulty with visual tasks. So getting lost, perhaps trouble driving when you're having to keep track of where the signs are, where the other cars are, what your GPS tracking unit is telling you. It may contribute to challenges in mathematics. So a lot of mathematical problems actually have visual spatial components, certainly in geometry, but also in problem solving more generally. So in some cases, this might rise to the level of a diagnosed learning disorder. In particular, if it's contributing to issues with mathematics, you might get a diagnosis of dyscalculia, or a specific mathematics learning disorder. And sometimes reading disorders, right? Because reading relies on visual spatial skills as well, because you've got to recognize and interpret the letters. So if this is the case, you can get academic support if those visual spatial deficits are interfering with academic functioning. For those who are outside of school and for those in school, occupational therapy can be helpful to learn compensatory strategies. And now here's a little representative data. So you can see that across a variety of visual spatial skills, the individuals with Turner syndrome are scoring a bit lower. And this is an example of the kind of stimuli or task you might find on a visual spatial test. All right, memory. Memory is an area that is not well studied in TS. So the existing studies at the moment are pretty inconsistent. It looks like object and location memory may be worse than verbal memory. So that would be remembering what an object is, for example, an array of multiple objects, or remembering where an object was in a particular location. And average to low average memory for faces, which is an area I myself struggle with. In real life, this might manifest as just taking more time and more effort to learn through visual means, right? And that happens in school, right? There's certain concepts that are taught primarily through pictures and diagrams, so it might take longer to work through that. At this point in time, there are no specific associated diagnoses with memory, but you can still get support. One idea is to actually use the verbal strengths, because in TS we usually see preserved or even enhanced verbal skills in the educational curriculum. And you can enhance visual learning by describing these visual materials aloud and using things like verbal mnemonics and tricks to link the verbal and the visual together. So down here, you see a kind of task you might use for remembering visual spatial stimuli. So you have to look at this quite complicated figure in A, and then try to reproduce it without looking at it. So you can see two children's different attempts here. The language, as I said, language is typically an area of strength for individuals with TS. So they tend to have enhanced receptive and expressive vocabulary. Receptive vocabulary skills are basically how many words you know and understand when other people are using them. Expressive vocabulary is your own use of verbal skills. Semantic language is typically preserved or enhanced. Semantic language is about the meaning of language, how words communicate meaning, and also how longer units, sentences, paragraphs, entire essays or books communicate meaning. Phonological processing may be enhanced. Some of you might remember learning to read with particular phonics. So these are the individual word sounds. On the other hand, there may be decreased verbal fluency in naming and problems with syntactic processing. So syntax is different from semantics. So it's not about the understanding and the meaning of language. It's about the structure of language, the rules. I don't know if anyone actually has to sit in class and map out sentence structure anymore like we did when we were a kid, like I did when I was a kid, but that's syntax. And fluency is things like, generating as many words that start with P as you can in a short period of time. And that's really kind of language that is tapping into executive function skills. And then we have pragmatic language. So pragmatic language is about how we actually use language in social situations. And this is really not well studied in TS. But because some people with TS do experience challenges in the social domain, this could be contributing to that. So its manifestation in real life would be strengths typically in aspects of oral and written communication. Because this is usually an area of strength, diagnoses would be infrequent, but that doesn't mean they can't happen, right? So a child may still qualify for a specific language impairment, which is when your language skills are much worse than your other academic skills, or social communication disorder, which I mentioned earlier. Because this is a strength, we can actually use it to enhance academic and work performance. For example, using oral testing or verbal presentation as a means to assess skills and knowledge acquired in class. But when an issue arises with speech or language and it reduces the ability to communicate or to perform in school, a referral to a speech or language pathologist could be warranted. So, and down here you can kind of see this is oral fluency. So you can see this is a task where some of the individuals with TS struggled. Whereas over here, we see receptive vocabulary and naming, and the individuals with TS are actually outperforming their non-TS peers. All right, motor skills. So one thing that can be seen is poor performance on perceptual motor tests. Perceptual motor means we're putting together the visual spatial with how our body moves to achieve something. So in real life, that might manifest as clumsiness. For a younger child, it might be delayed motor milestones. So a delay in walking, feeding themselves, dressing themselves, and also difficulty with writing. So, again, even though there's verbal strength, writing requires you to make these, particular movements that are very precise. Developmental coordination disorder I mentioned earlier. So this is a potential diagnosis that one might get if one had these motor challenges. In which case there'd be a referral to occupational or physical therapy, which would allow coaching and training of the motor skills. Early intervention for preschool age children is very important. We know across a whole range of domains that the earlier you start interventions, the better outcomes tend to be. And at school age, you can establish, again, academic accommodations as appropriate. So for example, maybe needing more time for certain tasks. Because it's going to take you longer to write. It's going to take you longer to draw your diagram. Here you can see a study showing measures of manual dexterity, ball skills, balance skills. I like this study a lot because it's really doing things that you might do in real life, right? So you can see that there are a fair number of girls who are at risk or impaired in this study. And over here you see some of the ways that they tested, throwing this beanbag into the circle. I was playing cornhole with my kids yesterday, the same concept. I don't know if everyone calls it cornhole, to throw the beanbag through the hole. This is a pegboard task, gets at fine motor skills. You have to take those little tiny pegs and put them into the right holes there. And then we've got a visual motor task where you're having to copy figures. Social cognition. So social cognition, of course, is about how we interact with and understand other people. So again, there's some inconsistent findings here, and this is an area where more research is needed. It does seem that children with TS are likely to have average or low average to impaired facial processing, particularly recognizing emotions, as well as either average or low average theory of mind. Theory of mind is our knowledge that other people have their own thoughts, ideas, and perceptions, and that they don't necessarily match our own. It's also about the ability to correctly identify what's going on in somebody else's mind. In adults, the experimental tasks for this often focus on facial expression recognition and the ability to follow gaze, as well as the ability to attribute mental states. So you can see here, these are kind of the 6 basic human facial emotions. We obviously have mixtures of these, and it gets much more complicated. But here we've got anger, disgust, fear, happiness, sadness, and surprise. So in this particular study, you can see that the women with Turner syndrome tended to perform worse across different emotions, but particularly for fear. And what was interesting is they also looked at how the participants actually looked at the images. So you can see that the individuals with Turners in this study were more likely to focus on the mouth and to look at the mouth more, and less likely to focus on the eyes, which is different from individuals without TS. And it's actually similar to the way individuals with autism spectrum disorders typically scan and think about faces, which is quite interesting. So in real life, this could be difficulty identifying facial emotions when you're interacting with other people, as well as poor recognition of other nonverbal cues, so like more body language, and possibly some difficulty initiating or maintaining peer relationships. We know that most young girls with Turner syndrome have high social motivation. They really want to form relationships, but sometimes struggle to do so. When there are problems in this domain, you might qualify for a diagnosis of social communication disorder or your daughter, or possibly in some cases, an autism spectrum disorder. So this used to be a little controversial. There was one study showing increased rates, but for a long time, nobody had tried to replicate it. There is actually a study that came out, a registry study in Scandinavia in the last couple of years that suggests that the rate is elevated in girls with TS. But it's still only a small proportion of the population. If this is the case, you'd want a referral to a psychologist or psychiatrist for further evaluation and treatment of poor social skills, as well as any issues that might come with that, like anxiety, depression, or low self-esteem. And some places you'll be able to find social skills group therapy, either through the school or through a community provider. That's actually something my own children have done. So how does this kind of play out on the larger scale? So the first thing I'm going to talk about is academic performance. So as I mentioned before, there is a higher rate of dyscalculia or mathematics learning disabilities in TS, and that's actually very common. So that's 50 to 75%. There could be inconsistent phonological processing and word reading. This is usually a strength with actually hyperlexia, like accelerated faster reading, but maybe some inconsistent reading comprehension. So this could manifest, at school as poor performance in your mathematics classes, and possibly less efficiency in reading. So again, taking more time, taking more effort. The associated diagnosis is specific learning disorder. And it's really important in these cases to establish academic accommodations, because those are going to allow children to get a developmentally appropriate mastery of the concepts and not fall behind in school. This could include tutoring. It could include empirically supported interventions. There are actual intervention packets for mathematics learning disability. And in fact, if you look down at this lower right figure, I think this is a really amazing study. This is one of the only studies to look at one of these interventions in girls with TS. And not only did they improve in their mathematics processing, the way their brains looked at mathematical problems changed. And that's what you're actually seeing in this picture here. It's really exciting. Certainly referral to an occupational or physical therapist can help address the perceptual motor and the visual spatial issues, and that can lead to improved academic and daily function. And it's really important to target the core deficits that are known to underlie mathematics learning disorders. So those are particularly things like representing the magnitude of numbers and then linking numerosities to number symbols. And there are a number, as I said, of like neuroscience empirically supported research, supported methods for improving mathematics processing. What about psychosocial? Now, I want to make clear the psychosocial picture in TS is only partially a result of the cognitive strengths and challenges. I don't want us to fall into a trap where we think that everything that goes on here is about what the girl or woman or other person with TS does, because all of these things are also affected by the way girls may be treated, right? So it does look like there may be some level of social withdrawal for some girls with TS. Potentially loss of interest or pleasure in activities, distress about teasing or bullying. They may find themselves dissatisfied with their self-concept or self-image. having fewer close friendships. Most of the studies to date suggest marriage at lower rates and less likelihood of cohabitating. Now, of course, as I said, some of this may reflect things other than the cognitive and social challenges, right? So it could be that, parents are concerned about the medical issues that their daughters will face and, may not encourage as much autonomy and independence. So that might delay girls, say, moving out of the home and entering into other relationships. It may be, obviously, social withdrawal and a loss of interest is a reasonable reaction to being bullied, right? So it's really important not just to teach girls the skills to deal with bullying, but to engage schools and other communities, whether those are, church, whether they're sports organizations, to address bullying at a wider level. That's going to improve the social environment for all children. So if someone is struggling in these areas, they might develop a diagnosis like major depression disorder, anxiety, or adjustment order. And jumping back, I also don't want to leave out the potential impact of dealing with infertility in TS, right? So this may contribute to the marriage at lower rates if people are feeling, that maybe they don't deserve to go down that path because of infertility. So it's really important that we address at a societal level those things that create an idea that there's only one way to be successful as a woman in the world. In terms of the intervention, a referral to a psychologist or psychiatrist is really important if someone's developing symptoms of depression or anxiety. Again, these are things my own children or my older child deals with. So you really do want to be aware of when children's behavior changes, right? Some children are always shy, and that's just part of their personality. But if you see a dramatic change in a child where they're no longer wanting to interact with their peers, when all the things that used to make them happy and joyful don't seem to be doing that, when they're withdrawing from you, those are all things to be aware of. In this case, individual psychosocial therapies might be helpful, whether that's cognitive behavioral therapy or insight-oriented therapy. There are a lot of different options. There are, of course, medications for treatment of mood and anxiety symptoms, which are very effective when they're indicated. And things like the Turner Syndrome Society and other peer-to-peer groups and parent-to-parent groups are really important for improving psychosocial outcomes and satisfaction. How we address other components of the condition is also really important. So I'll show you this data in a minute, but there's good evidence that targeting on-time puberty is really helpful in improving psychosocial function and avoiding depression and anxiety. Children who enter puberty late, just may feel very different from their peers, and that contributes to their mental functioning. As well as aggressively managing hearing impairment. So this was kind of a surprise from research. But in fact, there appears to be a strong association between hearing problems and negative perceptions of one's psychosocial situation. So what does it mean for education? So I mentioned before, this is a tremendously resilient population. So actually lots of studies have shown a similar or even increased level of educational attainment compared to the general population, which is a really big positive I want to emphasize. In terms of employment, there's also equal or higher employment status. So again, very good news. However, some women do express thoughts that they have a lower occupational status than would be expected from their level of education, or report less positive and challenging work experiences. And surveys suggest a retirement at an earlier age. One of the challenges with research on employment, education, and psychosocial skills is a lot of it is survey-based, which sometimes gives you sort of limited information about why you're seeing the pattern that you're seeing. So, for example, we can't necessarily say that people are retiring because they're dissatisfied with their work or because they're struggling with particular, cognitive or social challenges, or maybe they've got more severe medical conditions and they want to retire so that they can focus on supporting that aspect of their health. So these are questions that really need to be addressed more. And there is a real lack of qualitative research on Turner syndrome, where qualitative is going to focus less on these kind of graphs where you see the proportion of retired versus not, and more on the reported experiences of people with TS about their working and the reason they might make decisions like this. So I do want to show this one. I think this was a really powerful study where they were looking at determinants of quality of life in Turner syndrome. And you can say they looked at a lot of different things: educational level, what their social professional class was, how tall they were, how long they'd taken growth hormone treatment, characteristics of Turner syndrome itself, what was the karyotype, whether they had dysmorphic features or a heart malformation. And the two things that jumped out as predicting poorer quality of life were hearing problems, that's what the otological condition is, and when puberty was either spontaneous or when it was induced. I'm sure a lot of people are wondering about how hormone replacement therapy might impact some of these outcomes. So in terms of estrogen, there's been at least one study there have been several studies showing that adult women with TS have a similar cognitive profile to the one I described, even if they had preserved ovarian function and went through puberty spontaneously, or if they had adequate estrogen replacement. So that would suggest at least that estrogen during puberty is not a major determinant of the cognitive strengths and challenges. And that makes sense because they tend to be there already in childhood. So they don't emerge during adolescence, they're earlier. That being said, there was one study looking at low-dose estrogen administration of girls 5 to 8 years. They saw some modest improvements in verbal and nonverbal memory, as well as improvements in processing speed and motor function. Now, of course, I said verbal and nonverbal memory tend not to be areas of deficit. So this might be something that happens to anyone who's taking estrogen and not reflect the estrogen deficit. And as I said before, age-appropriate somatic sexual development. So is associated with positive self-concept, social adaptation, and perceptions of health. In terms of androgen, which in the clinic is often oxandrolone when it's applied. So one study has indicated that low doses of oxandrolone may improve working memory in girls aged 10 to 14, but a different study in adults found no effect and actually higher reports of anxiety and depression. So at this point, it wouldn't be possible to say that it had either positive or negative effects. In terms of growth hormone, the studies exist do not reveal a strong effect on cognition. And actually, recent research calls into question a kind of long-standing assumption that short stature would lead to psychosocial problems. So a recent systemic review actually suggested that most of the studies that reported effects of short stature and GH on cognitive outcomes had a really high risk of bias, so they're not necessarily trustworthy. In one of the kind of best designs and epidemiologically oriented studies, found that neither adult height nor estimated height gained through growth hormone treatment had an effect on psychosocial outcomes. Now, that certainly doesn't rule out individual experiences in terms of negative height. For example, reporting of bullying on account of short stature in children. So what are the recommendations? So this is what the 2016 guidelines said. And I should say the guidelines are planning to be updated next year. So there may be some changes here, although I don't think they'll be dramatic ones. So neuropsychology and allied behavioral health services are an integral part of comprehensive care for girls and women with TS. Now, in an ideal world, preventative pediatric and adult health care would actually take place annually. So with annual developmental and behavioral screenings, with then referrals to specialists as indicated, and ideally conducted, and ideally having more intensive assessments conducted at key transitional stages in education. I'll show you what those are in a minute. Academic and occupational adjustments should be sought to accommodate challenges when they occur. And we should promote peer-to-peer and parent-to-parent contact with TS support and advocacy organizations. Oh, there's something I left out of here. So I will say that ideally these kind of screenings would take place with your general practitioner. So at your annual well health visit or your child's annual well health visit. But some people may not have that in the context they are, in which case you may need to to have other specialists that you're working with address these issues or ask them to integrate it into the healthcare plan. Okay. So what kind of professionals might you be working with, either as a parent of a child with TS or as someone with TS? So you might work with a clinical neuropsychologist. These people have specialized knowledge and training in the applied science of brain-behavior relationships. They perform evaluations to confirm a diagnosis and characterize a child's functioning. And they help shape the expectations for you as a parent, for example, and will recommend interventions based on the child's strengths and weaknesses. And you can actually take those then, for example, to the school to get an IEP, or if you're at a private school to get your child's individualized plan. So clinical neuropsychologists are often the first port of call if there's a potential challenge to be addressed. So they tend to focus on the testing side, not necessarily on treatment and interventions. So they recommend things, but they may not be the one you go to implement them. Behavioral developmental pediatricians are medical doctors, so they're board certified in pediatrics with special expertise and training in evaluating and caring for children with developmental, learning, and behavioral problems. So they can also do evaluations and would also be involved potentially in implementing treatments. Psychologists, so these are clinical psychologists, can perform their own diagnostic evaluations, or they might act on the findings of another specialist, like the neuropsychologist. And they're equipped to provide evidence-based mental and behavioral health services, both for individuals and for families. Occupational therapists help people participate in the things they want to do and the things they need to do through the therapeutic use of everyday activities. So this is really focused on everyday function and everyday tasks. If there are concerns about speech and language, going to a speech language pathologist is a good idea. These are people who work to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, also swallowing disorders in children and adults. If there are concerns about ADHD, anxiety, depression, a psychiatrist may be a helpful part of one's team. So that's a medical doctor who specializes in mental health, including emotional and behavioral disorders. I put it later in the presentation that I forgot. So what should the annual screenings actually look like? So in the US, we recommend that all children and adolescents receive annual developmental and behavioral screenings starting in the first year of life. So if you've ever taken your young child in for a visit, maybe you filled out the ages and stages questionnaire or something like that to look at developmental milestones. Annual mental health screenings are also a recommended part of care for adult populations. So you may or may not have seen that in your own doctor's office. So optimally, those are part of your primary care visits. But where those services aren't delivered in primary care, specialists caring for girls and women with TS should consider putting that into their model of care and focusing on psychometrically robust screening tools. So screening tools that are well supported by the literature. And the 2016 guidelines provide a list of those for clinicians. The ideal measure is short, simple to score, and would be validated in multiple languages. So it could be used across different countries. And of course, across people speaking different languages in the US. So I said I'd talk more about key educational transitions. So the big ones are going into preschool, entering into primary school, transitioning to high school, transitioning, if chosen, into higher education, vocational schools, college, university, graduate school, and any time that a difficulty arises. So we shouldn't feel we have to restrain ourselves for these particular time points. But they are time points when the kind of challenges change. And of course, the brain itself is changing and maturing throughout all these periods. What don't we know? So we don't know very much about what learning and cognition look like in infants and toddlers with TS. So I mentioned this is kind of my special interest area. So we've conducted some of the first studies using neuroimaging and behavioral testing to look at infants and toddlers with TS. We do see that some of the neuroanatomical features, so what the things like brain size of different regions, connectivity between different brain regions. Some of the things we see in older children and adults are already present very early. Other things aren't, which is good news because that means, again, early intervention might actually prevent those from arising later. And we also do see that in general, infants and toddlers with TS have a pretty normal developmental profile, which again is good, but there may be some specific early markers of risk. We don't know very much about how aging affects learning and cognition in people with TS, so that's a really huge literature gap. We don't know much about how clinical experiences impact learning and cognition. So I showed you some of the data on hormone therapy, but there are, of course, many other clinical experiences that someone with TS might undergo, whether that's having surgery to put in ear tubes or for cardiovascular issues, the cardiovascular issues themselves. We don't know a lot about how these might impact learning and cognition. We also don't know how to predict what specific cognitive and behavioral issues might arise in a particular individual. So pretty much everything I showed you today is about group differences. But people aren't groups, people are individuals. And there's tremendous variability between different individuals in which cognitive challenges they experience. And wouldn't it be great if we knew enough to look at things like, genetic factors, clinical experiences, hormone levels to say, we think this person is going to be at high risk of this outcome. Let's start an intervention now. We don't know very much about the efficacy of available treatments for cognitive and psychological symptoms in girls and women with TS. So I mentioned, we think it's logical that interventions developed for other groups would also have positive effects here, but there isn't a lot of actual empirical data showing that. The data I showed you on the mathematical learning is one of the key exceptions. All right, so I'm going to end with this slide here, which is really trying to summarize a lot of different things I've talked about today, but particularly talking about understanding cognition and learning in TS as something that evolves across the lifespan. So we have here this prenatal period. And actually, I should have said this is another gap, right? We actually now are developing techniques that allow one to have better scans of the brain during fetal development, which would be really interesting, hasn't been applied in TES yet. But this is a really foundational period for brain development. So as early as kind of 8 weeks gestation, kind of the primitive structure of the brain, the neural tube is forming. This is the time when most of the neurons, your little gray cells, are being born. Almost all happens prenatally. They're traveling to their final locations in your brain. That's neural migration. They're hooking up with each other. And that's what axonogenesis is. The axons are the ways neurons communicate. And then also there are these ways of what we call apoptosis, is programmed cell death, which is a normal part of development, occurring late in pregnancy. Then we have synaptogenesis. Again, this is about how neurons communicate with each other. So during this time, the genetic vulnerability for TS is already present. TS may affect placental function, right? And that could have an impact on how the brain develops. Cardiovascular vulnerabilities may already be present. But then we transfer into the area we know more about, right? So we've got infancy, where there's a relatively normal profile. Some children do already show risk for language or motor delays. And there is some suggestion that as children move from 1 to 2 years of age, there's a slower progression in perception and motor skills, which might be precursors of later challenges. The typical neurocognitive profile emerges in childhood, and that's when we start seeing effects on academics, on peer relationships, now that they're in a school environment and interacting with other kids. That's going to have an impact on their self-esteem. This is the time when ADHD is typically diagnosed. I should mention that with autism spectrum disorders, they can be diagnosed with good validity as early as about 2 years of age, but are often not diagnosed till later. And then you enter adolescence, right? So there's some subtle changes in profile as the brain continues to mature, particularly the brain systems that are involved with regulating our emotions and doing those executive functions. So again, it's important to continue to monitor academic achievement, peer relationships, self-esteem. Adolescence is often the time when anxiety and depression first rear their ugly heads. So it's very important to get in early when that's an issue. And then of course we have the transition to adulthood, where really now we're looking at establishing autonomy and independence, finding the jobs that satisfy us and help support us financially, finding the relationships, whether those are friendships or romantic relationships, supporting new families that contribute to our emotional well-being and our satisfaction. And as you can see, as you travel through the lifespan, not only do we see the brain continuing to development and refine its circuits, but all these other things come into play, right? Low levels of estrogen and androgen, clinical issues, whether autoimmunity, hearing problems, visual problems, GI disease, surgeries that might be necessary for these, GH treatment coming on, now being encouraged earlier and earlier in life as soon as girls fall off their typical growth trajectory. Estrogen treatment coming on typically in early adolescence, around age 12. And then, of course, dealing with infertility often becomes a more pressing issue as girls get older. So I will stop there. Hopefully it was about on time. Somehow my clock disappeared. So, but I'm happy to take questions.
Hi, Rebecca. The first question is, please address strabismic amblyopia added to the already inherent spatial relationship problems in TS.
Ooh, that's an excellent question. I'm afraid I'm not going to be able to provide a detailed response because I'm not an expert in eye problems. But I think it's clear that if you're having any visual impairments that could contribute to visual spatial challenges. We do know that at least some of the visual spatial challenges appear to relate to differences in brain structure and connectivity. So there tends to be a lower volume of some specific areas of the brain, the parietal and occipital cortices, which are involved in higher order visual processing. So this is kind of after those earlier, when the eyes are actually sending the visual signals to the brain. That happens in some earlier brain regions. But they're starting to hit visual cortex. That's kind of your primary visual area. And then they're being passed on. So we really think those occipital to parietal connections, which are responsible for tracking objects in space and movement, are the area where the brain may have developed differently in TS. And we see that too in kind of the connectivity between those parietal and occipital regions and the frontal regions of the brain.
Very good. So Laura asks, she says, I have a theory that hearing loss in childhood is closely linked to social communication issues and some of the psychological symptoms mentioned. What are your thoughts on that?
Yeah, I would certainly agree with that hypothesis. If you're having trouble hearing, particularly as a young child, that's so crucial to how your language, how you learn language, including social language. If you're struggling to hear what other people are saying, that's going to be an issue. So again, really important to have hearing support. And we do see, ear tubes, for example, being put in quite early to help address that. But I think that would explain that association I showed where the individuals with hearing difficulties were reporting less, psychosocial satisfaction and quality of life.
And then the next one says, what would you suggest if someone is struggling for structuring their writing?
Ooh, so I'm a professor and I deal with this and pretty much all my students, right? Writing is really difficult. And so I myself am trying to explore what are the techniques that one could apply to improve writing, particularly organization, and how we translate our thoughts, which we understand so well, into words and structures that other people can understand. So I'm going to answer this not so much as a scientist, but as an educator. So I think that outlining before one writes is extremely useful. It's also really useful to do what we call reverse outlining, where you take the piece that you've written and you go through and create an outline, because then you actually get to see what you really did as opposed to what you thought or hoped you were doing. And that gives you an opportunity to kind of move things around. If people are interested, Cindy, I don't know if I can find it quickly, but I do have a link somewhere to a website on reverse outlining, which I think is very helpful for that.
Okay, we have a lot of questions, so I don't think we'll get to all of them, but the last one that I'll ask, because a few people asked a similar question about people with TS being diagnosed or having symptoms of autism. and what accommodations one says an adult woman might receive, and the other is just more about any tips for, support with that kind of diagnosis.
Yeah. So this is one of those scenarios where if there are concerns that this might be something that a child or an adult qualifies for, that you would want to get a neuropsychological assessment. Those are available to adults as well as children. Obviously, the kind of tests you take as an adult are different. There'd be a lot of questions about your developmental history. Sometimes one might even kind of, with a child, you're often asking the parent about the history. So you might talk to your own parents about your developmental history if you're being diagnosed or evaluated as an adult. If you get a diagnosis, if you're a child, obviously that would go into the IEP. So any recommendations that the neuropsychologist made could go into the school. We know that, so a lot of the interventions for autism at this point are behaviorally based. So there's debate, right now about whether the traditional treatment for autism, which is applied behavioral assessment therapy, so ABA therapy, was probably the best supported early intervention for autism. But there's a lot of debate now about whether it could be psychologically damaging for some people to go through ABA, and this probably depends a lot on the training and experience of the provider. But it is, it is really focused on getting someone with severe issues into a place where they can learn higher order skills. There are definitely other behavioral interventions. I mentioned social skills training. So for adolescents, that can be really important. As I mentioned, my own children went to a summer camp. They have ADHD, but they were going with kids on the spectrum as well, to really train people on emotional regulation and social skills. So there may be support groups for adults as well that focus on kind of social skills training. There are no pharmaceutical treatments at this point for the core deficits in autism spectrum conditions. There are certainly treatments to deal with kind of comorbid issues related to, anxiety or depression. Some children with autism have self-injurious behavior. So there are also some medications that may help with that.
Thank you very much, Rebecca. We appreciate your presentation, very informative. Those of you, if you just want to stay on, we're going to bring Benita Bamba back because we lost the electricity, so we're just going to continue her session right after this one. So we really appreciate.
Yes, so don't log out.
Yep, we really appreciate.
We're just going to switch from Rebecca to Dr. Bamba. Thank you, Rebecca.
Thank you so much.
I'll go into the chat. Am I able to go into the chat?
I don't think so. If you can.
Okay, yeah, because it's Q&A.
I think it's off. So if anyone else submitted a question, then we're going to take all the questions, send them to Dr. Knickmeyer and ask if she'll please respond. And then we will send out the text of the Q&A to everyone.
Okay, excellent. I do see an option to type answer. I'll try and use that, but I might also lose that option when Benita comes in. So,
okay.
All right, thank you all so much.
Thank you.
Thank you. Turn her camera. She can turn it on.
I see you, Benita. She's up at the top, so she must be a presenter.
Best to unmute.
You're right there.
Can you hear me? Oh, I can't hear you. Let's see. Can you hear me?
Sorry. Yes.
Okay, so when I try to start my video, it says you cannot start your video because the host has stopped it.
Oh, yes. Yes. There you go. Should be fine now.
There you are.
It's so good to see you again.
Nice to see you guys. Thanks for hanging in there.
Thank you for hanging in there. You only stopped and started with us about 14 times. So we are going to just let you go right into your slides. Go ahead.
Yes, so this session is by Dr. Vanita Bamba. She's going to be presenting on hormone replacement therapy, thyroid issues, and diabetes and TS. So we are definitely, I know, because we started like 30 minutes late on the last session. So we're going to give you your full 45 minutes. So, so we're going to end a little bit past the 3:55 that we anticipated. So for those that want to stay on, you have your full 45-minute presentation. So.
I am not able to share my screen.
Okay, hang on. There you go.
Let's see.
We'll fix that. Okay, see if that works.
No, let's see. No, for some reason it's letting me share Zoom tabs, but not PowerPoint.